Healthy Minds, identifying and treating adolescent insomnia to support mental health. A few reminders before we begin. All attendees are in listen-only mode, so hopefully you can hear us, but we are not able to hear you. So if you have a question during the session, we'll ask you to use the Q&A icon, which should appear at the bottom of your Zoom control panel. If you'd like to use closed captioning today, you should also be able to access that from your Zoom control panel, which is usually on the bottom of your screen. At the end of our time together today, we'll ask you to complete a couple of brief evaluation questions. These are helpful for us as we continue this work. We'll repeat this again, but the recording, slides, and any resources will be shared via email. I'm Emily Baldy. I'm at the National School-Based Health Alliance. We are a national nonprofit that advances the work of school-based health centers. We do this by offering technical assistance, convening the field for networking, and supporting quality improvement initiatives. Today's webinar is part of our NTAP work. So we receive funding from the Health Resources and Services Administration to support the work of health centers, particularly as it relates to school-age children. I'm not sure if we have a slide later on, but that work covers a variety of topics. So today we're talking about sleep, but that work also encompasses emergency preparedness. We've recently done some work on vision services, healthy relationships. So if you're interested, you can visit the e-library on our website. Our learning objectives for today. We hope that by the end of our hour together, you'll be able to talk about the connection between sleep and mental health, that you'll be able to describe symptoms of insomnia, and that you'll be able to identify some practical clinical strategies you can use in your practice with pediatric patients. I want to acknowledge and thank those of you who submitted questions ahead of today's webinar. It was really helpful for us to see what was on your minds. Many of those questions will be addressed during Kayla and Casey Jo's talk. Some of them we will hold for the Q&A section at the end, and there may be some that we won't get to. But again, thank you so much for sharing those in advance. I'm really excited and grateful to have our two presenters with us today, Dr. Casey Jo Cottrell and Kayla Bartlett, both of whom work at Barber Community Health Association in West Virginia. Because I am screen sharing, I don't have your bios in front of me, so I'll ask you if you're willing to introduce yourselves and share about your wonderful work in just a moment. But if you've just joined us, so glad that you're here today to talk about healthy sleep, healthy minds. The slides and recording will be shared via email and posted on our website. You're welcome to submit questions throughout. Some of them we may interject with, others we may hold until the Q&A. Anything I'm forgetting before I turn it over to you all?
I don't think so.
Okay, all right. All you, thank you.
All right. I'm going to adjust here so I can, oh goodness,
See everything.
it's not quite what I wanted to do, but
It's okay.
there we go. Okay. I wish I could see myself to an extent, but maybe not. All right. So I'm Dr. Casey Jo Cottrell. I'm a licensed clinical psychologist here in West Virginia. I'm also the director of school-based health here in Barber County. Go ahead.
I'm Kayla Bartlett. I'm a physician assistant, so I do the medical work here. I've been doing school-based in the county for about 6 years, and I work primarily with our elementary and middle school students.
Yeah. All right. So you can go ahead to the next slide if you'd like. And to the next one.
That's just
That's just us. All right, so I'm going to get started today talking a little bit about why we should be asking about sleep. And really, this is going to hit on that first objective as we're looking at the intersection between sleep and mental health. And I promise I won't read off of the slides for all of them, but I do think that some of this information, making sure it's exact, is really important. So when we're looking at prevalence rates for ages 16 to, there we lost it. Emily, it popped up the slides. There we go.
You see it? Okay, thank you.
6 to 18, we're looking at almost 20% for insomnia, and this is for actual clinical insomnia, not just symptoms of insomnia. We're also looking at close to 10% for ages 13 to 16, so it's quite a few. And I'm going to jump to the bottom there where it's talking about having 3 insomnia symptoms was associated with a 6.2-fold increased risk of suicidal ideation, 10.4-fold increased risk of making a suicide plan, and 10.5-fold increased risk of making a suicide attempt when compared to those with no insomnia symptoms. And so I think that those numbers are really striking, and it hits home when we look at that, in particular because we talk so much about risk assessments and depression and mental health in schools. I think that's a big thing that's up and coming right now, and we're not talking about sleep quite as much, but when we look at these numbers and we see that's having a huge impact. Another thing that's important is recognizing that insomnia is a strong predictor for later development of depression in adolescents. And what we find is it's kind of a bi-directional relationship. So someone who develops insomnia is more likely to develop depression later on. But also if someone has depression, we should also be asking about their sleep, because what we find is a large portion of people who have depression also are experiencing at least symptoms of insomnia, if not full-blown clinical insomnia. One of the questions submitted ahead of time was asking about how does insomnia interfere with academic performance. So we start seeing impairment in cognitive performance, poor executive functioning, increased risk-taking behaviors. All of these things can have an impact on lower academic performance. You can advance to the next slide if you like. Okay, so some of the boring stuff, but still important because we have to bill and we have to get paid, right? So when we're looking at diagnosing insomnia, insomnia is a little bit unique in the sense that there is an F code or a behavioral health diagnosis for insomnia, and then there's also a G code. So today we're going to talk about the behavioral health side of things. So if we're looking at the DSM-5 TR criteria, the big thing that we're going to be looking for is dissatisfaction with sleep quantity or quality that's associated with difficulty falling asleep, staying asleep, or waking too early. It's got to cause some sort of clinically significant distress or impairment. And so this could be it's impacting their ability to function at school. I think that's what we see most common. It needs to happen at least 3 nights a week. And then on the next slide, we'll see that it also needs to happen for greater than 3 months. And then also something that's important to note, it needs to be despite adequate opportunity for sleep. And so I think this is what I run into just from an anecdotal point when I'm working with adolescents in the schools a lot, is that a lot of them aren't giving themselves the opportunity to sleep in some ways. And then they're oversleeping in others, which we're going to talk about here in just a little bit. But that is part of the criteria. Yeah. Next slide. All right, and then acute insomnia is also important to note because sometimes what we'll find is someone brings their child in because they recognize pretty early that this is happening and that they're not sleeping as they should be, but it's not yet been 3 months. That's what we call acute insomnia, and it can also be classified as other specified insomnia disorder if you're a behavioral health provider and you're looking for that F code. Next slide.
Yeah, so I think the big thing that we're looking at when we're talking to adolescents is when do we start to see this? So like Kizzy Jo mentioned, sometimes we will have parents that notice these things early on, and so they'll bring them in for those questions. But most of the time, at least in our practice, we're screening for that at their annual well child visit. And so it can look a different way depending on what age we're talking to. But usually we start the conversation with this, how many hours are they getting to sleep at night? And so they'll give you the 8, or some will say 10. If you're talking to high school to middle school, generally I'm asking them, and usually the answer is no, I don't know. And so that kind of springboards what time are you going to sleep? What time are you waking up? Are you staying asleep through the night? Are you taking naps at the end of the day? A lot of times kids come in, it's like, well, I didn't go to bed till 2, but I took a nap as soon as I got home from school, or something like that. Then the other instance, sometimes we have to ask parents that. And of course, sometimes there is a difference of how long they're sleeping on a school night versus a weekend when they're waking up in those times. So based on what those answers are and what they should be, or they're sleeping more than they should, or they're not sleeping enough, then we can medically start looking, okay, well, is there snoring involved? What are some of the other symptoms? And we can follow up and do referrals based on that. Medically, here later in the conversation, we're going to talk about what referrals look like for behavioral health, though, since it's our main focus for today.
Yeah. All right, next slide.
Before I advance,
Sure.
thinking about Dr. Cottrell, when you see a patient for the first time, right, you're not doing an annual well visit because you're a behavioral health provider, but this is part of that initial intake conversation you're having with patients for behavioral health visits?
Yes, generally whenever I'm doing a behavioral health intake, I usually roll it in with all the other health behaviors. So I'll talk a little bit about appetite, right? When we're screening for depression, we're checking in on appetite, check in on sleep. How well are you concentrating? What's your energy like? That kind of stuff. And so I always am checking in about sleep. And I also generally follow it up, even if they're like, oh, I sleep 8 hours a night. Then I'll follow up and say, okay, what does your schedule look like on the weekdays? So what time are you generally going to sleep? What time are you waking up? What about the weekends? What does that look like? And sometimes the math doesn't math. And so I'm like, you gave me the answer that you thought I wanted to hear, but that's not actually what's happening. Yeah.
Thanks. And I think there may have been a question on the previous slide about what is a parasomnia? Thank you, Danielle, on the SBHA team for flagging that for us.
Sure. Yes. Did you see that in the slide?
Yeah.
Yes. Okay. So a parasomnia it's another sleep disorder that is like a quasi sleep disorder. And so if you get into the DSM, you're going to see there are a lot of other sleep disorders. So you're going to find like nightmare disorder, like there are a lot of different sleep disorders. And so it's checking to make sure that you're ruling out some of those other things. Yep.
Thank you.
Mm-hmm. All right, so I want to address a couple of questions before I get to the slide that we had in the pre-questions bank. So one of the questions was, what are helpful ways to counter misinformation about sleep and increase buy-in? And that was a great question because that's absolutely one of the biggest things that we're going to run into. And a question that I like to pair with that someone else had was, how can we change sleep patterns when it's happening in the home? And I think that's one of our biggest barriers. I know not everybody here is school-based, but that's what we talk a lot about in school-based too, is, we're not in the home. Sometimes the parents aren't even here if we're doing school-based sessions. And so how do we get that buy-in? So my answer is generally a lot of psychoeducation to help students understand how and why their body is working the way that it's working. And we're going to talk a little bit about breaking down some of the cultural misinformation that we as a whole society, not just kids, but all of us have about sleep. And once I help them understand what that looks like, then we can work together to do what I call a behavioral experiment. And so I'll say, like, are you willing to try an experiment? Do this for 2 weeks and see what happens, right? Like, I know that you can do anything for 2 weeks. We can try it out and see what happens. And then you'll know if it works for you. And if it doesn't, you can come in and tell me I told you so. And so sometimes I will be able to get buy-in with kids from that place. So whenever I have identified that there is some sort of insomnia symptoms, insomnia disorder, you don't have to be meeting full criteria for insomnia disorder to be able to apply this information to a student. And honestly, even kids that are sleeping with a healthy sleeping pattern and don't have any complaints can benefit from this, because that doesn't mean that they won't in the future. And this information doesn't just apply to pediatrics. This is across the lifespan. And so it's really just good information to have. So the first thing that I talk about with patients is I use the example of, we as a society treat sleep like money in the bank. We think that we are supposed to earn or deposit so many hours of sleep every single night into the bank. And we think that if we don't get that much, we need to make up for it in some way. And so I'll say, how much have you been told that we need to earn? And almost everybody says 8 hours. Sometimes I will have pediatric patients that will be like 9 or 10 because, there's information out there about getting more sleep in childhood and, that kind of thing. But generally the answer is 8 hours. So I'll be like, yeah, that's what everyone says. And for the general public who do not have insomnia, that's generally a pretty good rule of thumb. If we don't have any trouble falling asleep, we don't have trouble staying asleep, we should give ourselves the opportunity to sleep 8 hours. However, trying to force that much sleep if we're having trouble can create some issues, which we're going to talk about here in just a minute. So next slide, please. So then I'll follow that up and say, If we aren't getting those 8 hours, we often will try to make up for it in one of three ways. We will either sleep in, so we'll extend our wake time to later in the day. We'll start napping or dozing in the afternoons, which I hear a lot, that like after school nap, or like, well, I sleep in third period, like after I have breakfast and I have a slow class, and so it's fine. Or they'll try to go to bed earlier than typical. That one I find in adults way more than I do in pediatrics. The first two, they're sleeping in on the weekends and they're napping either at school or after school. Next slide. And I will tell them we're going to come back to those three ways here in just a second. Okay, so then I talk a little bit about our sleep drive, and I like to describe it like a stretched rubber band. I'm going to change where I can't see myself. There we go. I'm talking with my hand, so I want to be able to see myself here. So I will say our sleep drive is kind of like a stretched rubber band. The more hours that we're awake, the more light we're getting during the day, the more physical activity, all of this stuff is stretching our rubber band, making us sleepier and sleepier throughout the day. It's increasing our sleep drive. So what we want is for our sleep drive to be super, super stretched. So when it comes time to fall asleep, we are sleepy enough for it to snap back pretty quick and easy, versus it just kind of flopping around and us having a really hard time being able to fall asleep. So then next slide. So if we put all of those things together, if we think about those three ways that we make up for poor sleep the night before, think about how it sabotages the stretching of your rubber band for the next night. So if I have to get up for school at 6 o'clock because my bus comes at 6:30, and I do that Monday through Friday, but then a Saturday comes and I don't get out of bed until 1 o'clock in the afternoon, which is a common one that I hear, right? We're looking at 5 hours. I don't do great mental math, but I think, no, 7 hours. 7 hours. Don't do great mental math. I'm a behavioral health provider, okay? 7 hours. We're looking at 7 hours later that our rubber band is stretching, meaning come Saturday night, we do have stretch on our rubber band, but it's missing that 7 hours that we typically would have had. And so then we have trouble falling asleep. And oftentimes they're not worried about having trouble falling asleep on a Saturday night because they can sleep in on Sunday. They don't have anything going on. It's the weekend, right? And so then that's when we're catching up on video games and, you know, whatever that we're doing on Saturday nights. Sunday night comes and we try really hard. Parents say, hey, it's a school night. You need to get to bed at a normal time. You need to go to bed at 9 o'clock, whatever it may be. Oftentimes I will see that they sleep in on Sundays as well. Sleep drive is way messed up. It's not stretched near enough. Then they have trouble falling asleep. And what we will find when we have that overlap of depression and anxiety, what will happen is they lay down, try to force themselves to go to sleep when they're not ready. And then that's when their mind starts, right? And so that's when it's like, I'm worrying about what the week's going to look like, or those worthlessness feelings, or those suicidal thoughts, all of that stuff starts to build, which increases stress, which decreases the likelihood that we're going to be able to fall asleep. So that's what's happened when we're sleeping in. Let's say it's a Thursday afternoon, you've been getting up at 6 o'clock every day, you haven't been able to take a nap all week, and you're just like really tired and trying to get caught up, and you take that nap in third period. You were stretching up until third period came, and then when you fall asleep, what did you just do? You snap back your rubber band, right? And so is it going to start stretching before bedtime? Yeah, absolutely. But we're missing that big stretch. Generally, the recommendation is anything more than 20 minutes. Avoid anything less than 20 minutes. I generally, for the teenagers, because if you give them an inch, they're going to take a mile. I just tell them no napping, no sleeping, and no napping whatsoever. But you will see some research out there that talks a little bit about that, like less than 20-minute power nap isn't too bad. And we're going to talk about some sleep hygiene stuff here in just a little bit. Any questions, Emily, so far before we move on to the next slide?
It doesn't look like it. I'm just doing a double check. I think we're good. Thank you.
Okay. All right. Next slide, and Kayla will kind of put this together into some rules.
Yeah. So again, looking at those three things, what are some really good, again, talking with high schoolers or adolescents, we want to give some good boundaries because they do well with that. And so you want to have a consistent wake time. So we try to go by the general rule of don't make that sleeping in more than an hour of what you would normally wake up for school. So you want to keep it in within an hour window plus or minus of what your normal wake time would be. Again, because we're trying to make sure that rubber band stretches as much as I can. Next rule will be no napping. Again, there may be that 20 minutes of news out there that you can do that, but for high schoolers, it's easier just to, hey, let's not do a napping because it snaps that rubber band. And it's normally, for at least what I've seen, after school. It's like I got home at 3 and I slept till 7. And so we encourage, instead of, because we don't want to just be negative, you can't do this and you can't do that, give them some ideas of some things they can do that are some activities of join an after school program, or maybe try and go for a walk with a friend or meet up with somebody. Again, encouraging homework might be okay, but they've been kind of sitting all day. Getting up, getting some movement, and not letting them sit down where their heads can just bob and go to sleep is a good thing to do. So, and then the third thing, again, try not to force you to sleep at night. We really want to make sure that we're not adding to those feelings and that stress of trying to make myself feel tired, especially if that rubber band's not stretched. And so, whereas we're trying to really stick to that consistent wake time, we don't stress as much about the forced go to sleep time. Again, we want to allow, hey, try and give yourself that 8 hours of sleep, but that's kind of the last thing that we're looking at because we don't want to force that stressful thing. And actually, if you'll go to the next slide for me, Emily, we're going to talk about some like non-stimulating activities that can really help when you're trying to wind down before going to bed. And so these are just some things that we encourage. We try not to do anything that's going to get us amped back up. So, right, you want to kind of stay away from screens or from like high physical activity, but listening to music, an audiobook, turning the lights down low, folding laundry or putting laundry away. I have kids that they're like, well, I have a pile of things everywhere. I'm like, okay, well, focus on putting one pile of whatever. Mom asked you to put this basket away, put that basket away, then kind of thing. Coloring, jigsaw puzzles, again, things not on a tablet or a phone or a screen, actual physical books, journaling, anything else quiet, knitting. I've had some friends get into some embroidery lately, things like that. Kids are really into making bracelets around here. So anything where it's going to kind of like allow their mind to do something that's just going to allow them to settle down, but also not make them be like, I should be sleeping, I should be sleeping, I should be sleeping.
So. Well, and when it comes to that, the buy-in piece of it too, I really try to lean into kids and talk a little bit about like, listen, I know that you can't force yourself to sleep, right? Like if I asked you right now, I want you to fall asleep. I mean, there are some humans that can do that. My husband being one of them, and we hate those humans, right? But most people can't do that, right? And so I will lean into, however, what we can do is control when we're going to wake up. We can set alarms. We can ask friends to make sure that we are setting up coffee dates on Saturday mornings to be able to get up and spend some time with. We can ask our parents to help make sure that we're awake. Like we can control our wake time. And the great news is our body is wired to be able to sleep. And sometimes people will come in and have a lot of feelings of being disheartened about their bodies and their sleep and just feeling like this is impossible. I'm never going to be able to sleep because I can't force myself to sleep. And so if we lean into what you can do is force yourself to be awake. And now that you understand this sleep drive, if you can use that like a power, it's like a superpower. If I can use my sleep drive to build up enough to be able to sleep, eventually your body is going to start to kind of rewire itself. And we're going to talk a little bit, I'm getting ahead of myself here, but we are going to talk a little bit about these principles I'm pulling are from these behaviors that we're talking about. I'm pulling from a treatment called cognitive behavioral therapy for insomnia. And what we'll find is generally what I find for high schoolers is this fixes the issue. But sometimes people do need a little bit more of the full-blown CBTI, which we will talk about. All right, next slide. Okay, so let's talk a little bit about sleep hygiene because that's the hot topic with sleep, right? Most people are talking about sleep hygiene when they're talking about sleep. And unfortunately, I think it's doing a lot of harm. And someone actually had a really great on-the-nose question. They said, how do bedtime rituals like sound machines, room darkening, etc., contribute to insomnia? And in my opinion, one, you cannot treat actual insomnia with sleep hygiene. It's just not going to happen. And it's doing some harm in the sense that it's creating this pressure to be able to perform when it comes time to sleep, right? And so we're encouraging these things like a cool, dark room and a sound machine, and even some of the things that we were talking about with good, healthy, like non-stimulating activities, right? If you have insomnia, those things are not going to put you to sleep. And then you're going to feel even more frustrated because you feel like you're doing all of the right things, and it contributes to this kind of like helplessness. And one of the sayings that I really like is sleep hygiene. It's a healthy practice, but it doesn't treat insomnia. And it's kind of likened to seeing a dentist. So a dentist is always going to tell you to brush your teeth twice a day. But if you've got a cavity, they're going to drill it out, right? Like if you have insomnia, we need to treat the sleep, and we're not going to treat that with sleep hygiene. However, if you've had a cavity, you should still brush your teeth twice a day. Just because we're drilling out the cavity doesn't mean that you shouldn't still brush your teeth twice a day. So sleep hygiene is not bad, and it's not a bad thing for us to be talking about and to be encouraging. However, I think we do need to be aware that if there are some markers of insomnia, we need to be addressing those more than just with sleep hygiene. All right, so next slide.
Before I before I advance us, there was a question asking to please give examples of sleep hygiene practices. So I heard some of them, right? A cool, dark room,
Yes.
maybe a sound machine. Um, are there any others that you want to call out? If when
Yes.
we say sleep hygiene, here's what we mean.
Yes. So generally, those are what we're talking about. No exercise before bed. No nicotine before bed. No talking about caffeine. Cool, dark room. All of that good stuff. No screen time before bed. All of those things. And the next couple of slides are actually I'm going to lean into there are a couple of sleep hygiene pieces that I do think pack the most punch. That I do always talk to teens about. And the biggest ones are going to be caffeine and then screens before bed. So we're going to talk about those two next. So the next slide is caffeine.
And what I'm hearing from you about sleep hygiene is that,
Mhm.
yes, it's helpful and it's important for our patients to know about these practices. And if they're experiencing insomnia, they may need some additional supports and interventions. Am I hearing that correctly?
Yes, correct. Yes, that's correct. And really, oftentimes sleep hygiene leans more into bedtime practices rather than really leaning into that consistent morning wake time and the no napping, which those are, depending on what sleep hygiene resource you're looking at, those oftentimes are listed in there, but unfortunately it's listed in with a bunch of the other things. And so it's the least likely ones that they're going to want to follow, right? It's easier for me to put my phone down and listen to a podcast or to not exercise before bed or whatever it may be than to get out of bed at 7 a.m. on a Saturday instead of, right? And so if we don't have that education piece of it with the sleep drive and the rubber band and like why we're asking them to do this thing, that's why you don't get any buy-in, because good luck getting them out of bed if they don't understand why you're asking them to do that. All right, so let's talk a little bit about caffeine. So usually what I will talk about with the students is if we go back to, I'm going to go where I can kind of see myself. Okay, so if we go back to the idea of this stretching of the rubber band, there's a chemical in your brain called adenosine that is the sleep promoting chemical, and it builds up in your brain the longer that you're awake. And so the way that I like to think about it is it's kind of like the hands grabbing hold of that rubber band and stretching it. So the more that it's building up, the sleepier that we're getting, the more ready for sleep that we're getting, okay? Caffeine, the way that it works is it affects the brain by blocking adenosine receptors. And so I like to think about it, it like blocks your hands from being able to grab hold of that rubber band and stretch it. And it has to wear off before adenosine can really be released and start stretching that rubber band again. And the half-life of caffeine can be up to 10 hours. And so generally my recommendation is no caffeine past noon. And another thing we're going to talk a little bit about, I think it's maybe on the next slide, but I'm going to go ahead and go over it now before we switch to that next slide. So if we're grabbing hold of that rubber band and we're stretching it, that adenosine is building up. One of the other things that kids talk a lot about is melatonin, right? And so basically the way that these things interact is adenosine is stretching the rubber band. Once melatonin gets turned on, melatonin starts to build in your system. And once it reaches a certain level, it tells your hands, hey, you can let go and you can fall asleep. It generally takes about an hour, anywhere from 30 to 60 minutes, once that melatonin gets triggered to build up enough to reach that threshold to tell your hands, hey, it's time to let go of that rubber band and for it to snap back. The key to turning on that melatonin and start building that is darkness coming into your eyeballs instead of light. And so when we talk about screens, which was another one of the questions I think that came up on the pre-questionnaire survey thing, was what about screen times and how should we be talking about that? And so, because again, it's another hard sell to get kids to not doom scroll at night, right? But if I talk from a biology standpoint about, listen, think about it. Prior to electricity, how did people know when they needed to be asleep and when they needed to be awake, and how did we regulate those things, right? And so our body is wired that when there is the absence of light or there's darkness coming into our eyes, it turns on that melatonin. And anytime that there's light coming into our eyes, it turns it off. And so I have found that kids react really well to the stretching of that rubber band, and it makes sense to them. So if you can advance to the next slide.
We have a couple of questions in the
Sure.
chat. Um, one was about reading before bed and whether
Okay.
that can disturb sleep.
Yeah. When it comes to reading before bed, I usually talk to kids a little bit about, okay, if you feel like you are a reader who's like, I can't wait to read the next page, it depends on what I'm reading, right? It depends on the person. There are other people who they're like, yeah, reading puts me to sleep and it wears me down and I can wind down that way. Also, how they're reading and the way that with which they're reading is important. So at the early stages of treatment, we want to avoid like a Kindle, things like that. If we can find a paper book, we also want to turn off overhead lights because that simulates the sun, and we don't want any light coming straight into our eyes from a device either. And so usually something kind of like this, where it's kind of like a little bit above and it's low light coming down, like a lamp on a nightstand, that kind of thing, to be able to read with a book is fine. But again, it's gonna depend on the person a little bit on how much that keeps them awake. Yeah. Same thing with audiobooks, right?
Yeah. I was gonna say it also
Yeah.
depends on like what you're reading. If you got a kid that's listening to something that's really high intensity thriller kind of thing, that's your body's gonna respond. Your body responds to stress all the same way. It doesn't matter if it's real or not. Yeah. And so like then that's gonna build some things up. And again, we're working with all kinds of different hormones that are then gonna mess with our receptors and everything. So I think that's more of a it can't. So I don't know if that helps. It's an either or. It depends on the patient. And so that's just going to be a conversation you're going to have and encourage. But I would also agree with Casey Jo of like early on, I would try and do less. But again, this is talking a little more about some sleep hygiene things of that, because we don't want to put that pressure of like, you can't read before bed. Well, if they've been doing that their entire life, that may stress them out a little bit more. So it's going to be per patient kind of thing.
Yeah. Yeah.
Thank you both. The other question was, do most energy drinks work the same as caffeine?
Yes. Yep. That's what you're finding. Same thing.
Yeah.
Yeah. And what we're finding, unfortunately, is a lot of the energy drinks, some of the kids don't even know what's in them and how much is in them. And we're packing in way more than what you would from like a cup of coffee or from like a Coke in the evening with dinner, that kind of thing. Yeah, for sure. Something we should be screening and talking about.
And I imagine that coupled with no napping, I could imagine hearing no napping and thinking like, okay, great. I will have a cup of coffee or I'll have, and so I imagine that those two things might go together.
Yes.
When we talk about how are we going to stay awake?
Yes. And I will oftentimes have a conversation about like, listen, I know what I'm asking you to do is incredibly difficult. And I'm not gonna lie, you're gonna be pretty miserable for a day or two. Let's be real. And the kids kind of know my approach is usually like, I'm gonna give it to you straight, and they're gonna give it to me straight kind of thing. And so I'll be like, listen, I'm gonna give it to you straight. This is not gonna be fun. However, a couple of miserable days where we make it a little bit worse before it gets better, with the understanding your body and knowing why it's getting better and why we're making it worse, is so much more powerful than feeling like you're feeling now for the next 5 years, 10 years, 20 years of your life, right? So that can help sometimes too. All right. So another thing with the sleep hygiene, which I talked a little bit about some of this, but a consistent routine can notify your brain that sleep is coming. So having that 30 to 60-minute wind down period can be kind of helpful. And so this is where we're talking about with the release of melatonin, dimming the overhead lights, and looking at how much we can prevent light coming into our eyes. And another thing too is we want to reduce the sleep pressure, right? And I will tell the kids, I don't care what your bedtime is. I don't care how many hours of sleep that you get at night. I really genuinely don't care. What I care about is that you can function during the day where you wake up feeling rested. You can stay concentrated and active in class. You can go to sports in the evenings as you need to, right? Like if you can do that on 6 hours, great. If you need 10 hours to do that, great. At the end of the day, we want consistency and we want you to be able to function and to feel good. Because notice the criteria for insomnia doesn't say anything about how many hours, right? It's all about they're dissatisfied with the quantity or the quality because it's impacting their functioning. And so I will also tell kids, like, again, I don't care about your bedtime. And that will help with buy-in sometimes too. So I'll be like, I don't care about your bedtime. And my goal for that 30 to 60-minute wind down period is not for you to fall asleep. My goal is for you to be able to relax. I want you to make that goal. Stop putting the pressure on yourself that you have to fall asleep at a certain time. Because that's when we start doing what we call sleep math, right? We start looking at like, okay, it took me an hour to fall asleep. Now I only have 7. I'm only going to get 7 hours of sleep. Oh no, now I'm only going to get 6.5, right? And we start doing the math of what that's going to look like and stressing about those numbers. And I will tell them like, all right, it doesn't matter. It doesn't matter. I want you to wake up feeling rested. And if we need to have a couple of really horrible days to make that happen, then we'll do that. And then I will also tell them like, don't make yourself miserable. Stop tossing and turning for 3 hours trying to force yourself to sleep. If it's been about 20-ish minutes, and I'll tell them, don't watch the clock, but 20 minutes feels different than 60, right? If it feels like it's been about 20 minutes and you can tell, like, I'm not going to fall asleep anytime soon, I'm not on the verge of it, whatever, get up and do one of those non-stimulating activities that Kayla was talking about until you feel sleepy enough. And maybe that means you don't go to sleep until 3 o'clock in the morning, but if you still wake up at 6 o'clock and then you don't take a nap and you don't have your energy drink in the afternoon, right? Guess who's going to be real tired the next night? And what I don't want you to do is go to bed at 7 o'clock or even 9 o'clock, right? Like whatever your a general appropriate bedtime is, when you're sleepy enough, then you can go to sleep and it'll start to correct itself at that point. All right, next slide, unless we have questions.
I don't recall, it may be that we had planned to save this question for later, and you've touched on it a little bit already, but there's a bullet point on here about screens. And I'm interested in, that's a hard conversation with adults. I'm interested in, gosh, how do you talk about that with patients? And what are some of the ways that you help them think about new possibilities related to phones and bed?
Yes. So generally, I will have a conversation with teens and adults, and really, honestly, we're seeing phones even in elementary school. So really, with all ages. The biggest one I hit on is helping them understand that biology with the rubber band. Like, what is that doing to the stretching of your rubber band? You're not allowing that melatonin to build up, so your hands are not going to be able to let go of it, right? It's also stimulating your brain, and it's hard for your brain to be able to kind of wind down from those things. And if I feel like I'm having trouble with buy-in, or I'm starting to get some of that, like, oh no, I can't let my phone go anxiety, or that anxiety of like, what if somebody needs to get a hold of me or whatever it may be, it takes a little bit more time. And this is where therapy is a little bit more suited because we have more time versus, a well child check. You guys have how long to do a well child check?
30 minutes.
30 minutes, yeah, right. Where I have an hour-long session oftentimes. So I will talk with them sometimes about understanding how social media works and how they have been designed to be able to pull us in. I'll talk a little bit about that dopamine release in your brain and how when you put your phone down, it takes about 5 minutes for that dopamine to wear its way out of your brain before you no longer feel like I have to like pick it up right away. Those notifications are popping up on your screen for a reason, right? Like it's a behavioral thing. And it's going to be really hard to put down. Your brain is literally wired and hacked by these systems to want to have to pick it up. It's a physical urge to pick it up sometimes. And so then we'll talk through, okay, what are some things that we can do to break that cycle? What are some things that we could replace it with? And that's going to be different from patient to patient. And sometimes I have to have conversations with parents about like, hey, listen, if we really want to address this, we need to put the phones in the kitchen starting at 9 p.m. or whatever time it may be, right? Like the charging station needs to be somewhere else. And talking with the kids about like, you're going to go through almost like a withdrawal period. It's not going to be easy, and your brain is going to have to adjust and learn how to be without it for a while. And what does that look like? Yeah.
All right. So the last thing we were talking about making referrals, and of course we said if there's some medical things that are contributing to sleep, obviously you want to address those too. But if we're looking at a diagnosis of, especially that F code of insomnia, and especially if we're talking about chronic insomnia, more than 3 months, then here's where we need to look at. And so if they're just having trouble kind of following those sleep rules that we were talking about of no napping, waking up within the hour, things like that, probably just any behavioral health provider. That's just something that they need to address behavior-wise and go in that way. But if we're having a patient they're having trouble with the sleep rules, but they're following the sleep rules, but they're having some trouble like meeting the criteria with insomnia, then that's when we're going to talk about the CBTI, which Casey Jo's going to go into a little bit further here soon. And so that's going to be a specific training. Now, that's not just a behavioral health person. Anybody can get this training, but that's when you're going to want to look a little bit further into that. And then obviously medically, if the patient doesn't meet the criteria for insomnia, but you're still having some fatigue and some daytime issues and things like that, we might want to look at a referral to a sleep specialist or any other kind of symptoms that you're noting.
Yep, for sure. So I think what you're going to find, and I'm kind of skipping ahead again, but I had another question. Actually, I think it's on the next slide, asking about, do we feel like pediatricians and primary care providers are adequately trained about sleep problems? And the answer is no, but neither are behavioral health providers, right? CBTI, I preach this to anybody who will listen. Like, CBTI is one of the most effective, easy to use, easy to learn treatments that can pack such a punch and make such a difference for so many different patients, and not near enough people are trained in it. No. It's not something that it was really talked about in my doctorate program. It's something that I pursued post-residency and all of those things. It just makes such a difference. And what we find is if you have someone who has both clinical depression and clinical insomnia and you just do CBTI, the depression starts getting better. And if we think about it, think about how these things work, right? Like, if you are sleeping better and you wake up feeling more rested, you have more energy to be able to do your homework. You have more energy to be able to socially engage. You have more energy to be able to manage your relationships with your parents, and you're not as irritable and cranky. You're outside getting more vitamin D, right? Like, all of these things are helping treat your depression. So then you start feeling better, and overall you start managing better. Your grades are getting better. Like, your functioning is improving. And this is again, anecdotal, but it is way easier for me to fix your sleep than it is for me to fix your depression. And so if I fix your sleep, your depression starts getting better, and you now have more resources for you to be able to engage in the things that I'm asking you to do, like behavioral activation, to be able to treat your depression. However, again, unfortunately, there aren't a ton of behavioral health providers who are trained in CBTI. And so I encourage you, if you are a medical provider or you're working on a team, to be able to just go back to your team and check in and say, like, hey, I heard about this CBTI thing. Does anybody have any experience with that or training? Maybe we can all sign up together. If you want to advance to the next slide, we can show some resources for that. Just as a disclosure, I'm not affiliated. I don't have anything to do with this program. I don't get any money or kickbacks from it or anything like that. But this is a program that I had gone through as my first introduction to CBTI. It's wonderful. It's all self-paced. It's broken into lots of little different modules and videos, which makes it really easy to be able to do when you have no shows or patients or snow days, if you're school-based, that kind of stuff. And it's fairly affordable. I think it's $25 for students and $100 for regular providers last time I checked. And kind of like Kayla said, you don't have to just be a behavioral health provider. They train nurses and doctors and, other staff as well. So I think that was so maybe when we're thinking about that first one, I think the screen is opposite. So when we're thinking about that first one, yes, thank you. Most behavioral health providers, they're going to, if your patients are having trouble following the sleep rules, any behavioral health provider is going to be able to help you with that because they're trained to be able to help manage behaviors, right? That's no different than I'm having trouble managing whatever, following the rules or, setting SMART goals, those kinds of things. We can address that from any behavioral health standpoint. But if they are doing all of the right things and they're still having trouble with sleep, that's where CBTI is going to come in, because what we talked about today, some of these consistent morning wake times and things like that, that is pulling from CBTI, but CBTI, the three components are sleep restriction, which is where we are looking at a consistent morning wake time, stretching that rubber band, but we restrict you're not allowed to go to bed until much later than what you would expect. Sometimes we're restricting people down to 5. You're only allowed to sleep 5 hours a night. And if you want your morning wake time to be 8 a.m., you're not allowed to go to bed till 3 a.m., which sometimes it's really funny. People come in and be like, I can't sleep at all. I'm like, okay, well, you're going to stay awake till 3. And they're like, I can't do that. You would be surprised how many times I have that conversation. And then once you get them, it's basically creating a shock to their system, right? We're increasing that sleep drive so much that then they can fall asleep really easily at 3 a.m., force themselves to get out of bed at 8 o'clock because then they want to oversleep at that point. But we do that consistently, and then you start backing up your bedtime. So that's one of the first big components for CBTI. The other component is what we call stimulus control. And so that's what to do if this is for people who have a lot of middle of the night awakenings, which I see a lot less in teenagers. But it could happen. And so that's another piece of it. And then sleep hygiene is the third component for CBTI. All right. I think that's it.
I think that's it.
Thank you both so much. I know that we have a couple of questions in the Q&A. I also know that we have some additional questions that were submitted as part of registration. So if you have questions now, I encourage you to submit them in the Q&A. I'm going to stop my screen share so that I can access that list of questions that we have. All right, let's see what we've got. Okay, as I pull up the other document, I love these questions. You mentioned referral to a sleep specialist. Someone asked about when is a sleep study beneficial? Is there a connection there?
Yeah, what I have seen, and I'll let you piggyback on this too. If I am asking a lot of questions about like what time are you generally going to sleep, how often are you waking up in the middle of the night, and how long are those awakenings, and are you having any early morning awakenings, anything like that? If I'm doing that and I'm seeing that they are actually sleeping anywhere from like 7 to 9 hours, whatever it may be, they're sleeping well, they're following all the sleep rules, but they're like, I'm so exhausted, right? Like I'm so tired and I'm falling asleep in class, right? Like all of these things. That's when I start to look at, okay, do they need a sleep study to see if there's some sleep apnea or something else going on medical more so than behavioral?
Yeah, so about the same thing with me as well. So medically, when I'm sitting in there, it starts with the springboard of how many hours are you sleeping every night, and then that same conversation. And so I'm also sometimes I'll have a parent that says this kid is snoring, and so we have a conversation there and do a little more medical in depth. Also, we'll have sometimes they're like, I can't keep them awake. Like I'm driving them home from school, and within 5 minutes they're falling asleep in the back seat, kind of thing. Yeah. And so then they got 10 hours of
And
sleep
still sleeping
and
all
they're
night.
still sleeping all night and going to bed normal and not having an issue with that. And so then we're going to take a deeper. So that's generally also what I'm going to be referring to a sleep specialist, or sometimes for kids, I may do like an ENT for an apnea kind of thing, or from there. But that's usually I'm looking at when we don't see any other reason that they should be this tired from a sleep side of things. We're not seeing any signs of insomnia, that kind of thing. Then that's when I'm taking a deeper look somewhere else.
Thank you. You touched on this a little bit, but this might just be an opportunity to say it all in one place. We had a couple of questions submitted ahead of the webinar about resources for parents, information to share with parents. I loved what you said about like sometimes if the phone is feeling really hard, that's an opportunity to talk with parents about working together on that. But other info that you want folks to know about talking with parents?
Yeah, I think one of the questions asked about like if I have any like handouts or things like that. And not that they're not out there. I just don't generally use handouts for a couple of reasons. One, I'm generally in school based, and so oftentimes I'm having phone conversations with parents. They're not always right there. It's not easy always to be able to get a handout with them. And two, I find with students that oftentimes they'll just shut down if I hand them a piece of paper. They shove it in their folder, and it's never to be seen again, kind of thing. I have had a lot more success with the conversation about the stretching of the rubber band. Yeah. And that seems to kind of stick with them. And so I find it really helpful if I'm giving this information to the kid to follow it up if possible with the parent and give them the same education so that when they catch them like wanting to take a nap or whatever, being like, what's that going to do to your sleep drive, right? Like, what's that going to do, the stretching of your rubber band? We need to work together for this. And honestly, like the cultural misinformation that we have about sleep is for the adults just as much as the kids. Because what I find sometimes is sometimes the kids have the sleep pattern because so do the adults. Yeah. And so just sharing that information with the whole family can be helpful.
Yeah, I think our big thing in school-based is definitely patient education. And so, I mean, it's everywhere medically, but definitely in patient education. And so being consistent in the conversation with a student as with your patient as you are with the adult that's helping them promote these things is big, and no matter what we're doing in school-based. But I think especially with this, so if they all have the idea of the rubber band in their head and not having the pressure of bedtime as much as they're having the idea of like, okay, we're all going to get up on Saturday morning at 8 a.m. and go for a walk and those kinds of things. I think it really helps just a whole group, the whole household. But again, the biggest thing I think is that conversation. So questions can be asked back. And again, we're just both not big on handouts and they just don't get home. They get thrown in the bottom of lockers and they just don't get there. And so it's just easier to have a conversation with the patient face to face and then calling the parent and guardian and following up that way. And it's just really seemed to be more beneficial there.
Well, and I like that you brought up the bedtime thing too, because you're exactly right. Oftentimes the parent is the one putting that bedtime pressure on them. And so having that conversation and giving that information with the parent relieves them from that stress of having to force, like, I need you to be asleep by this time, or, whatever it may be. Because sometimes the parents are just trying to do the best that they can, and they think that they're doing a good thing by like really stressing, like, you weren't asleep until 11 o'clock and I put you to bed at 9, that kind of thing. Yeah.
Thank you. Yeah. You gave some examples, but how do we promote the waking up in the morning consistently? Hot tips?
Yeah, that's a great one.
I need that.
We all need that, right? It's hard. Okay, so a few things. If they have an iPhone, which a lot of them do, and I don't know about Android, sorry, I'm an iPhone user, but you can create sleep schedules within the health app on an iPhone. And so it will automatically create a reoccurring alarm so that they don't have to remember to set it. Mm-hmm. That can be really helpful. And it will put their phone into like sleep mode, which can sometimes be helpful as well. So that's a good one. If you can get them to get someone who cares about them in their life to be invested as well. And so if you're working with high schoolers, sometimes this is like, listen, does your girlfriend or boyfriend like really want you to help get your grades up and you need to be able to sleep to be able to do that? Will they be willing to make sure that they're calling you and getting you out of bed? Can you help get them to invested in that? Sometimes it's a parent, right? Can we get them invested? Can we, one of the things that we can use here is on Sunday mornings, a lot of the kids go to church. And so they're like, okay, I can't sleep in on Sunday mornings because I have to go to church, but then they take an after church nap. So that's another thing that you have to fight. But if it's like, okay, can we schedule something on Saturday morning too, so that both on Saturday and Sunday, even if it's just a FaceTime date, right? Like whatever it may be, that you can do from your house. So those are some.
We use reward systems a lot too.
Yeah.
So like have something ready that makes you look forward to getting up. And so, I mean, I've also had patients be like, their parents have started putting their phone in the charge station and they're like, hey, if you're up and in the kitchen by 7:30, then you can be on your phone for 30 minutes kind of thing. Yeah. It's like, hey, whatever you need to do because sometimes parents too are like, well, if they're getting up at 7:30, I have to get up at 7:30. And we're like, you do.
And that's hard.
And it is. It's changing a whole schedule. And so it's just like finding those positive reinforcement things of like a schedule or whatever, something that's rewarding to them. Or like I've had parents be like, oh, we're just going to do a big breakfast together. We haven't done that in a long time. So whatever it is of like that gets you not just awake, but also kind of out of bed so you don't fall back asleep an hour after you've been awake or something like that. Yeah. We found like just kind of like a reward system, just something to look forward to.
And I will sometimes say like, I know that that's hard, but is what you're doing right now easy?
Right.
Like we're having this conversation for a reason. You told me that you're not happy with, the way that you feel and whatever it may be. And sometimes I will get buy-in by saying like, listen, I know that you came to see me because you're sad and you're depressed and whatever it may be. Here's what the research says. And I'm telling you right now, if we can get this sleep under control in the next week or two, you're going to have a lot more resources at your disposal to be able to address some of these other things. And, sometimes that can be helpful.
Thank you both. I think we'll do one more question. I know there are some that we're not going to get to. Thank you for submitting them, but we got 2 questions about middle of the night wakings.
Yes. Okay. So generally what I talk to students about if they're having middle of the night awakenings are a couple of things. One, that might be when you want to look at more full-blown CBTI, because sometimes what we find is middle of the night awakenings. I like to think about, it's the easiest way to explain this. So this is going to sound really silly, but bear with me. I work with teenagers. So I think about sleep kind of like pizza dough, right? And if I have enough pizza dough for a 6-inch pizza and I hand it to Kayla and I'm like, here's enough for a 6-inch pizza. And she's like, I don't want a 6-inch pizza. I want a 10-inch pizza. And she tries to stretch it to 10 inches. What's going to happen? It's going to be really thin. The quality is going to be crap. It's going to tear in the middle, right? And so what we have to do is kind of like pack it back down and then slowly expand it so that we don't have holes in it anymore. That's what happens with middle of the night awakening sometimes. Sometimes people are they're giving their body the opportunity to sleep 10 hours, but they're having these huge middle of the night awakenings because they're trying to sleep too much. And now they're in this circadian rhythm or this pattern of that happening, and we need to fix it. And so that's what you're going to find with sleep restriction in CBTI. So if that's happening, I recommend looking at more CBTI type principles. Another thing, just good practices. If someone is like waking up from a nightmare or whatever, and they want to be able to fall back asleep, there's one of the big things is do not pick up your phone. Don't turn on the overhead lights, right? Because what did you just do? You put light into your eyeballs, and what's that going to do, right? It's going to turn off that melatonin, and it's creating wakefulness. And oftentimes what kids will do is they check their phone. They hit their phone because they don't have a clock in the room, so they'll check their phone. And then when they do that, they happen to see a notification, and then that sucks them in, right? And so I will talk to them about like, hey, this is what that cycle looks like. This is why we need to put your phone across the room. And it doesn't really matter how long that you're awake. All that's doing is increasing that anxiety about I was awake for an hour and a half or whatever it may be, right? We're looking for quality, not quantity. If you wake up and you are trying to fall back asleep and you're tossing and turning and you're trying to force it and you feel like it's been more than 20 minutes, same thing as when you go to sleep, just get out of bed, right? Get out of bed, do something non-stimulating. You don't need to look at the clock. Your alarm is set. It doesn't matter what time it is. Do something non-stimulating until you're tired enough to be able to try to return to sleep, even if that's only for an hour, with the understanding that when your alarm goes off, you still have to wake up the next morning, start stretching your sleep drive. You're not going to have any caffeine and you're not going to nap and you're going to be really miserable, but then it's going to be really great the next night when you're able to fall asleep because you've used that poor night's sleep as a way to set you up for success for the next night rather than letting it sabotage that night. And I oftentimes will say, like, it's like losing the battle to win the war. You're losing the battle of sleep that night, trying to force yourself to sleep, with the understanding that you're winning the war of sleep overall, because now you know what to do to be able to use that sleepiness to help you the next night rather than sabotage you. Right.
Thank you.
Yeah.
All right, a little bit of wind down housekeeping. The first thing is that we will invite you to complete, I'm going to do my best to launch this now, a brief evaluation poll. As I shared, this is part of our NTAP work, and so we report back on how people felt about what we offered, but it also helps us know what is most valuable. So that poll should be available to you. If anybody doesn't see it, let us know in the chat or the Q&A. There we go. I see some responses coming in. As you're filling out that poll, I want to give a plug that we host each year an in-person conference. It will be in Washington, D.C. at the end of June. And if you enjoyed listening to Kayla and Dr. Cottrell, or if you think a colleague might benefit from this information, they will have a longer session at that conference where they'll be talking more about young people and sleep. So we would love to see you in person in Washington, D.C. I think if you want more from our fabulous presenters, that will be available to you, as well as lots and lots of sessions that address clinical skills, school-based health center operations, partnerships, innovation. So hopefully something for everyone. If you are not already, you might consider subscribing to our biweekly digest or following us on social media. In a moment, I'll share a slide about the funder of this project, but thank you so very much to our presenters. I learned a lot and it was a joy to listen to you. Thank you to our School-Based Health Alliance team behind the scenes who kept the logistics moving. And thank you to each of you for making time in your day. An hour is hard to carve out, and we're so glad that you were here with us. We will follow up with the recording and the slides. Otherwise, thank you for your time. Have a lovely rest of your day.
Thank you.
Thank you.
Thanks.